Hello everyone, my name is Do Hyun Park from University of Ulsan College of Medicine, Asan Medical Center, Seoul, South Korea. I'm currently a professor of gastroenterology. I'm here with
Gunn Huh. I'm a clinical full-time instructor in the Department of Gastroenterology, Asan Medical Center.
Yoon Song. I'm a clinical assistant professor in Dangung University Hospital.
We are here to discuss our study entitled Comparison of Outcomes of EUS-guided ablation and surveillance only for pancreatic lesions, a propensity score matching study with videos. Dr. Huh, could you explain the background of the study?
Sure. Pancreatic lesions, or PCLs, comprise a heterogeneous group of lesions with varying degrees of malignant potential, and management of PCLs remains controversial. EUS-guided ethanol ablation has been performed as a non-surgical treatment in patients with PCLs who are not surgical candidates or refuse surgery. However, the complete resolution rate of PCLs through EUS-guided ethanol ablation varies widely between the studies. Moreover, some studies on EUS-guided ablation excluded patients with presumed BDIPMNs. Therefore, the efficacy and oncologic benefit of EUS-guided ethanol ablation in patients with presumed BDIPMNs need to be elucidated.
Right. The efficacy of EUS-guided ethanol ablation could be influenced by various factors such as indications, ablative agent, and techniques. I have performed EUS-guided ethanol ablation since 2015 using rapid ethanol lavage technique in patients with PCLs, including enlarging presumed BDIPMNs or those with PCLs over 3 cm who are suboptimal candidates of surgery. In this study, we aim to evaluate the effectiveness and safety of EUS-guided rapid ethanol lavage, EUS-REL in PCLs including BDIPMNs, and compare the clinical outcomes of EUS-REL with those of surveillance-only group, SO group, using propensity score matching.
Professor Park, could you explain the rapid ethanol lavage technique? What is the theoretical background of this technique?
As you can see in this figure, EUS-REL is conducted through transgastric or transduodenal puncture of the cyst using a linear EUS with a 19-gauge needle. After aspiration of almost all the fluid in the pancreas cyst by negative suction with a syringe at the power of EUS-FN needle, 99% of ethanol was injected into the cyst. After 4 times of rapid ethanol injection and aspiration, all injected ethanol and residual cystic fluid were aspirated. 4 times of ethanol lavage can theoretically achieve 70.3 to 70.2% concentration in the pancreatic cyst. This technique might be helpful in improving the efficacy of ablation by overcoming the dilution effect of ethanol by dead space of the FNA needle and enhancing the concentration of ethanol in the PCLs. At the same time, by minimizing the retention time of ethanol in PCLs, procedure-related pancreatitis might be prevented. Dr. Song, could you introduce the study design?
Yes. This retrospective longitudinal study included patients who had visited Asan Medical Center between June 2007 and February 2022. Patients were divided into 2 groups, those who did not undergo surgery for initial treatment and underwent surveillance with imaging, and those who received the EUS ethanol ablation. The indications of EUS-REL were, first, unilocular or oligolocular cyst. Second, PCLs with 1.5 to 3 centimeters in size, including those presumed to be BDIPMNs with increasing cyst growth over than equal to 2.5 millimeters per year during the observation period. And third, PCLs over than equal to 3 centimeters in size with a high surgical risk or patient who declined surgery. We conducted a propensity score matching analysis between the EUS-REL and surveillance-only groups to construct a randomized experiment-like situation and minimize bias. Primary outcome was the cumulative incidence rate of BDIPMN progression in patients with presumed BDIPMN, which was defined as the composite outcomes of newly developed worsened picture or high-risk stigmata, cancer changes on follow-up radiologic imaging tests, and pathology research. Secondary outcomes were the efficacy and safety of EUS-RER, surgical resection rate, overall survival, and disease-specific survival in both groups.
Can you explain the result briefly?
Yes. Overall, 169 and 610 patients were included in the EUS-RER groups and surveillance-only groups, respectively. Propensity score matching created 159 matched pairs. In unmatched cohort of EUS-RER, the mean cyst size at ablation were 25 millimeters. The technical success rate of EUS-RER was 99.4%, and the radiology complete resolution rate following EUS-RER was 74%. Procedure-related pancreatitis in the EUS group was 13%, and most of them were mild pancreatitis. There was no severe complication.
How about the clinical outcomes of both groups before and after propensity score matching, Dr. Huh?
Yes. Before matching, during the follow-up of 411 patients with presumed BDIPMN in the surveillance-only group, 8 patients showed progression, 6 with worsened feature, and 2 with invasive carcinoma. In 159 matched pairs of both cohorts, 1 of 137 patients with presumed BDIPMN in the EUS-RER group, and 7 of 105 patients with presumed BDIPMN in the surveillance-only group experienced BDIPMN progression during follow-up. The cumulative incidence rate of BDIPMN progression was significantly lower in the EUS-RER group than that in the surveillance-only group after propensity score matching. EUS-guided rapid ethanol lavage showed a lower tendency of surgical resection rate compared to that associated with surveillance-only group. The 10-year overall survival and 10-year disease-specific survival were comparable in both groups.
Professor Park, what is the clinical significance of lower incidence rate of BDIPMN progression in this study?
EUS-RER group had a lower surgical resection compared to the surveillance-only group, which may be related to the lower BDIPMN progression rate in the EUS-RER group. This low surgical resection may reduce morbidity in high-risk surgical patients. The low BDIPMN progression rate upon EUS ablation therapy may have a further clinical gain because the absence of obvious residual PCLs after EUS-guided ethanol ablation can discontinue the prolonged radiological follow-up of PCLs, which is associated with substantial cost and psychological burden.
Professor Park, can you give more comments to the listeners?
EUS-RER for PCLs appears to be a relatively safe and potentially viable method for treating select patients with enlarging PCLs over 3 cm-sized PCLs, including those with presumed BDIPMNs and suboptimal candidates for surgery, if performed experienced hand. Further study involving a larger population and longer follow-up duration are warranted to validate our results. Thank you for listening.